Good evening, everyone, and welcome to the 19th monthly case webinar series. We're almost at 20, which is fantastic. We've had almost 20 months of doing a series like this and bringing you new cases each month. My name's Danish, and I'm a product specialist at Collective Minds. Today, we'll have the one and only Imran Lasker presenting cases during this webinar. I also want to say a special thank you to Dr. Johan Diem, who's also donated three cases for tonight's webinar. He's also a consultant radiologist from Belgium. We're also looking forward to having him as a guest in the new year, and also having him presenting some of his cases too, along with several other guests that will be coming in next year's webinar series. So a lot of things to look forward to next year. I'm also going to be sharing the collection for tonight's cases in the chat box below. If there are any questions you want to ask Imran, just use the chat box below. If there's any issues with getting onto the cases, just let me know in the chat box as well, or you can email support@cmrad.com and someone will be in touch to help you out. So yeah, with no further ado, I'll hand it over to Imran. Over to you, Imran.
So hi everyone, I hope everyone is well. My name is Dr. Lasker, for those that haven't come to any of these talks before, and it does feel like quite a long time we've been doing them. So thank you so much for those that do keep turning up and take part. And yes, very special thank you for donating cases for me to go through today. Hopefully I can do the cases some justice as well. So hopefully everyone can see my screen, and we're going to put the link up very, very soon. So you should be able to access this particular collection. So for those that don't know, this is Collective Minds Radiology, and this is what we're using as the platform to do this teaching. And they're the ones that support this all happening in the first place. And hopefully you'll be able to see, how good of a platform it really is for teaching. And I use it for a lot of my own courses and my own teaching as well. So just if I get a thumbs up that you can hopefully see the case that I'm opening up. So this is case number one. And this will, once it loads up, you should be able to see a chest x-ray. Can I just get a confirmation that I've definitely shown the right tab? Because sometimes that happens where someone has raised a hand. Okay, good. No, that's perfect. Excellent. So what we're looking at here is a chest x-ray, right? And first off, what I always do when I'm having a look at this chest x-ray is have a quick look, see if there's anything obvious. If there's nothing obvious, then we've got to start looking at, let's have a look at the orientation of this x-ray and see what it looks like. So when you come to this kind of orientation, as in how is the patient actually facing the plain film, you can see that sort of medial edge of the clavicle is over here, and that other edge of the clavicle is over here. But when you look at the spinous process, that's all the way over here. So they're slightly rotated, aren't they? They're kind of rotated maybe this way. This is not quite an en face image, right? And so this is, so we have to take that into consideration. That if we see any sort of, sometimes people say, look, that hilar looks really, really big. But then actually you have to take into consideration the rotation of the patient. And if you've got sort of a V-like structure, and then you kind of turning, will start to look more tubular and more round. And then you start to say that there's something abnormal. And if you do think there's something abnormal in that area and the patient's very, very rotated, you may need to send them back for another x-ray to make sure that there is no actual abnormalities and not actually secondary to the rotation. So a few people have given the answer. That's brilliant. Someone has written something else. Yeah, that's a good shout as well. So we're going to have a go. We have to go through this in a systematic manner, right? So I usually have a look at the lung apices and make sure that they look okay. And if we look at this one and zoom in, so we've got the zoom function here, and we sort of pan across like this, we can see that actually these lung apices don't look quite the same as one another. And for those that can't see it, if you look at that left lung apex, you see these linear kind of lines going all the way up like so, all the way up like so, all the way up like so. But if you look at this side, the linear lines go all the way up to here, all the way up to here, and all the way up to here, and then they just completely stop. And actually, all this looks very, very clear. And that can be a little bit difficult sometimes if you're not entirely sure. What you can do is draw a little square like this and draw a little square like this. And one of my consultants used to actually do a little kind of square like this, do a square there, do a square there, and really compare between the two. And once you do that, you can say, yep, you know what? There's definitely a difference in the sort of texture of the lungs there, i.e., there's no lung there at all located within that right apical region. So we could all stop there and say, yeah, you know what, we're sorted, it's done now. But actually, we do have to think about like what else could be happening here? And someone actually touched upon the possibility that there is some blunting of that right crostophrenic angle. So if we look at that right crostophrenic angle, we can actually see, yeah, you know what, there is something going on here that looks like a straight line. And you should never really have any straight lines in the human body, really. Most things are kind of curved or kind of wriggly and stuff like that. You shouldn't have straight lines. And when you've got straight lines, either someone has put something in there, or it's like a fluid level or some sort of difference because of gravity. And you can see, yeah, there is probably some sort of blunting of the costophrenic angle. And these are the times when you've got to be worried that, you know what, there's some fluid there. And you've also got a pneumothorax. So what could that mean? It could mean that they've had a bit of a traumatic injury. That could mean that they had a rib fracture of some sort, which can puncture the lung and they could have bled and all that kind of thing. And that's when you really got to do the hard graft and start looking at the ribs. I'm going to do the ribs just so that we can, oh yeah, you're going to get hemorrhages as well. So you can have like nodules, like a lung malignancy, I suppose, that can bleed. And yes, I guess in theory, there could also be weak points where you could have a pneumothorax. Not very usual, but it could happen. Sometimes patients have had, this can be iatrogenic. So someone, they've got a lung nodule or a lung lesion, and they've gone through with a biopsy needle and they punctured the lung essentially, and then you end up having a pneumothorax. Sometimes central lines can do it. There's all sorts of reasons that you can have punctured lungs, right? And sometimes they're just spontaneous. We don't exactly know why it happened or what happened, but we can just have a look like this and just have a good look around the ribs. And the way to do it is to really follow the ribs right from the back all the way around the side. And this is where it gets a little bit confusing. But if you really do follow, you can see all the way to this edge. And then you've got the anterior edge of the ribs. And just do that for every single rib, right? So let's have a look and just make sure there's no obvious fractures anywhere. And actually, on this particular X-ray, I can't say that we've seen any fracture, but there is definitely a fluid lesion, a fluid level there. So we do have to sort of highlight that. So if I was reporting, I'd say that there is a right-sided pneumothorax. I'd measure the distance that the pneumothorax depth would be, and I'd also say that there's some fluid located within the right hemithorax. And then in the context of trauma, this could be hemothorax. In the context, in it could be anything really until someone tries to put a tap in and with a bit more clinical information. But the main things you can really say is, yeah, 100% there's a pleural effusion and there is definitely a right-sided pneumothorax. And they're quite a young patient as well. So it'd be a bit surprising if there's going to be something sinister like a malignancy and that kind of thing. Because when you actually look at the bones and the edges of the bones, they look very, very flat, very kind of pristine. They don't look like an old person. And then also when you get older, you can actually get calcifications of that sort of the more chondral areas of the rib cage, and that doesn't look like that's happened here either. So this must be a youngish person who's ended up with this kind of particular issue. So anyway, yeah, a few people have got that. It's very well done. Fine, let's go to case number two. So this is a CT head. I'm going to kind of go between X-rays and CT, and then actually thanks to the person that actually donated the case, we've got a decent MRI as well, very decent MRI. So I'm very, very grateful for that. We're going to be looking, so we're going to kind of gear it towards most people's ability because obviously we have a fair few people who are just interested and some people actually do this day in and day out, right? So first off, let's go from the very, very top. We can see that this is an axial, so right from the top to the bottom, CT scan of a patient's head. And scrolling through, when you actually look at these sort of kind of crevice areas here, you can see these CSS space, they look kind of large. So they must be older, all right? They're not going to be a young patient. As you come further down, you can see that there's a little bit of low density located within these regions. So they've got a little bit of something called small vessel disease. And that's something that's very natural, can happen to people as time goes on. Normally in a periventricular location, doesn't usually go all the way to the edges of the brain parenchyma either, and it can be very common. And you can get sort of gradings of it. So you can have like mild, moderate, severe. And people, yeah, may want to report on that just to give an idea about the age of the patient. So as we scroll through, we can see the CSF spaces are here, and actually it all looks very, very symmetrical, doesn't it? And we have got the poll, and yeah, a few people have gone for a few different things. Okay, so but most people have gone for one of them. So I'm gonna end the poll there, and then the results should come up. So most people have gone for a subdural hematoma that they can see. So this can be a bit challenging, this one, because subdural hematomas are usually sort of crescenteric shaped ones. So if we do, oops, if we, let's get rid of that. So crescent shape should be like a crescent moon, right? Like this. And a extradural hematoma is going to be like this, right? And so someone actually told me that one looks like bananas and one looks like a lemon, right? So I guess a banana would be the subdural hematoma and the lemon would be the extradural. Now my mind still can't work with that. So what I end up doing is using a different kind of way. Is that, if you've got like a pair of glasses, right, like this, I can't even draw them on here right now. So pair of glasses like this. So they need someone who's got glasses need an extra pair of lenses for extra eyes, and therefore this would be This would be a subdural, extradural. So extra eyes is an extra as a lentiform, a lens shape, which would be an extradural, and the other one, the opposite, would be a subdural, right? So a few people have said they can see it. Okay, good. So when we're coming from the top, you can actually see there's some extensive, what looks like high density material located against the falx, and that can be very, very common. You can actually get calcifications of the falx cerebri, very, very common. And as you come further down, it kind of becomes a bit less so. But when you come down here, yeah, you know what? Maybe it's not because actually this looks very, very dense over here. And then if you look at the tent over there, it doesn't look so dense. And this area doesn't look as dense, right? Coming along like so, it starts to look a bit wavy and hazy, not quite that sort of calcified appearance that you have anywhere else. And it continues to be like this all the way along like this as well, right? So remember, the head is like a 3D structure, right? So if someone has a bleed and they're standing around and trying to, maybe they're not lying down straight away, it can actually sort of start to pull downwards, and then just lie along the tentorium. And so I just quickly shown the platform, which I think really is awesome that you can pretty much use all the platform, the planes that you normally use. Obviously, this is slightly thicker slices, which why it looks a bit pixelated, but the thinner slices would be a lot better. But you can see like how if you've got a bleed, it can start to pull down like this and come kind of sitting right along the tentorium. And that's exactly what's happening here. You've got blood sitting along the tentorium, so therefore this would be a subdural hematoma, right? And the way I'd actually report it would be a thin subdural hematoma that is lying along the falx cerebellum. And thankfully, the other things that we want to be making sure of is whether the person's got any mass effect as a result of it. And mass effect is where, if you've got a very, very big bleed, you can end up having sort of mass effects of things being pushed in the wrong direction, and that can result into a massive cascade of problems. But here you can see there's no real push of anything. Everything looks very, very midline. The CSF spaces look okay. So there's no significant mass effect from this subdural hematoma. So what we'd have to just say that yeah, there is a subdural hematoma, and they may want to get neurosurgical opinion if the patient's very, very confused, very, very well, may need to have further investigations. So yeah, a few people have got that. That's really good. Well done. Really, really impressed so far. Hopefully, I have some challenging cases for yourselves coming up soon. So this one was a young patient. It was trauma. So if you guys are doing this with me, do click on the cloud button because that does actually download the images, and you can see that sort of red sort of line that goes right the way across. And when that line goes all the way across, that's when all the images are downloaded, and you can have very smooth sort of scroll through. So I just got to wait a few seconds while that happens. But while that happens, we can see that this is a plain CT head. So the way to know that is if you actually look in this area over here, there's no contrast sitting within there. Okay, that's the basilar artery. None of the arteries look particularly bright. And actually, someone told me, and they are actually right. If you look at the mucosa over here, if they look slightly brighter, then it's a contrast enhanced images. If it looks sort of isodense with everything else, then you're probably not looking at a contrast enhanced study. But this is a non-contrast study. And let's scroll through from the very, very top, go all the way to the bottom, and we'll see what some of you guys think. And please feel free. I mean, some of you have gone for it, which is really good. But yeah, just feel free to sort of throw in your answers. Tell me what you think. I am interested, and it's actually quite useful for me to learn sometimes because sometimes someone spots something I didn't quite see the first time I saw the scan. Right. So we've gone all the way down, all the way down, all the way down. So someone said diffuse cerebral edema. So that's not a bad shout, but they are quite a young person. So quite a young person. And actually, one of the ways that you can try and figure out where they've got diffuse edema is if you come to the vertex and you can see some of the CSS bases, then you're going to be like, okay, I'm not entirely sure that you've got, a global hypoxia style injury. So diffuse axon injury can be really, really difficult to see on a CT scan, but I suspect you probably mean something else. And I'm going to go through that because I think you have probably seen what we're looking at. Okay, so as we come down, can you see the sort of little bit of brightness over here? So what I'll do, I'll zoom in a bit. So hopefully you can see. And can you see, and then what I might do is just window it very, very slightly. There you go. That might help. Can you see there? There is actually a small subdural hematoma sitting on that right side, right? And coming down, coming down, coming down. You can see it going all the way down like so. Not sure there's blood pooled down at the bottom there, but yeah, I think there is definitely a right subdural hematoma on this patient. So we could always say, yeah, okay, we're done now. Perfect. We don't need to look at anything else, but we do need to look a bit further. There's a bit more subdural blood over there, and we know this person's had a bit of trauma. And actually, when you come up to this area here, can you see that? That looks very, very sort of low density with a bit of high density there. And we think, okay, so that's right at sort of the front of the head, probably. And coming further down, you can see, yeah, there is a bit more of similar looking appearance over here. And there's a bit of a high density location just sitting within the middle there. So that seems to be kind of on the front of the head. Let's see if we can find any more. And actually down here, it does feel like there's a bit of hyperdensity. There's a tiny bit of hyperdensity, similar to what we saw earlier, but I would be a bit careful because there is a bit of artifact. I'll give you that. We come down here and the actual temporal lobes look okay, don't they? And actually, no, if you look there, can you see that? There's a little bit of a subdural bleed just lying along the temporal lobe over there. So from this, you can start to infer a few things about the initial injury, right? So it feels like this person must have had like an acceleration deceleration injury because when you have acceleration deceleration injuries, your head's sort of still moving forwards, your skull kind of stops, but your brain inside keeps moving forwards, and it will hit the frontal lobes, and it will also hit the temporal lobes, right? Because the brain will hit whatever's sitting anterior to it, right? And that's usually where you get something called contusions. And, I guess, diffuse axonal injuries, similar thing, but very, very small. But yeah, you do have hemorrhagic contusions on this patient in the frontal lobes, and you've got what looks like a right subdural hematoma and likely a left subdural hematoma as well. Now, the other thing that I quite like about the platform is that you can actually go into bone windows. And I think on this one, you just press number 3 and you're in bone windows. So we've got traumatic injury. We've got to have a look. We'll see what's going on. So facial bones are quite important because if someone's had an acceleration deceleration injury, maybe they hit their head on the front, maybe there's a fracture of the facial bones. I don't think I can see any facial bone fractures. Do correct me if you can see one, but I can't see any there at all. Nasal bones, they look okay. It doesn't look like they're fractured. The frontal bones look okay as well. And then someone has said it. Well done, you picked it up. So if we come down, come down, come down, we'll have to see if we can find it. Yeah, can you see that? So well done. Someone's picked it up. So just here, just right there, I'm going to just draw right around there. Can you see that? That is actually a fracture. So you got so you can have a suture, right? Not you can have sutures, and I'll show you what suture looks like. That's a suture over there, and that's a suture over there. And the way you can know they're sutures because they're like jigsaw puzzles, and you've always grown up with them. They've got to know each other, they've got close, and they're going to be like that. But when you get a fracture, that's like an introduction of something new, and that is a very abnormal sort of looking line. And actually, when you see that, you can see there is a fracture that is lying there. You come further down, it's going right along the base of the skull. And it feels like it's kind of going towards maybe the foramen magnum as well. So there is also a skull fracture on this patient. If we go back to brain windows, we're just going to make sure that there is no significant blood in the region of the foramen magnum. There's no crowding of the foramen magnum either. So yeah, so there are a few findings on this. So I think on first glance, when you go through it, you may not entirely see everything so quickly. But actually, when you look at it again now, you can see up there's contusion bleed there, a contusion there, maybe some contusion over here, just there and there. And then you start looking around here, you saw that subdural hematoma on the right. And when you a bit closer look on that temporal lobe, which is a very kind of common area to get bleeds and stuff, I think there could be a small bleed there. And actually, come to think of it, that might be a contusion bleed as well, rather than a subdural that I initially had said. And the reason I say that is because there's a bit of low parenchymal density around there. And by the way, if you don't know this, blood is like an irritant. So if blood contacts the brain, then it's going to start getting edematous, very angry, and then you get sort of vasogenic edema. With a subdural hematoma, there's still like an interface between the blood and the brain, and so therefore you wouldn't really expect like an adjacent hyperdensity or reaction to it. And actually, this one, I do think there could be a bit of a low density around this. I think actually that is going to be a contusion bleed there and a very, very common area. So temporal lobes, frontal lobes, and subdural bleed and a fracture on this one. So quite a few findings in this young person. And I know people have said, oh, is it a cerebral edema? This person's very young, all right? And I think one of the ways to do it is just have a look at that skull vertex and see if the CSF space are there, kind of a softish sign to see whether it's actual edema, so hypoxic, cerebral hypoxic edema. Right. So good. A few people have got that, and actually, you guys got that quite quickly, actually. Okay, so let's have a look at this one. This is so yeah. This is just to illustrate what some lung findings look like for those of you that are when you're doing reporting chest X-rays. Sometimes people will just say consolidation, consolidation, consolidation without really thinking about what consolidation really is. And have said this on previous lectures, but I've found this really good example of what we're going to talk about now. So actually, so let's go from the top. Is this contrast enhanced study? Yeah, you can see there is a bit of there is a bit of contrast sitting within the aorta. You can see some contrast sitting within the pulmonary arteries, but none of these are particularly bright, are they? So the aorta is not bright, the pulmonary arteries are not bright. So this is not a CTPA. This is not an aortogram either. So therefore, what phase is this? It's actually a portovenous phase. You can see the portal vein is there, and that looks brighter. So the portal vein is here. Hang on. The portal vein is here. Portal vein is here, and the aorta is here, and this looks slightly brighter. So therefore, this must be a portovenous image. And what they've done is taken one go through in that particular phase, right? So let's scroll through, and we can see that, yeah, when you look at that's the aorta, right? No, that's the pulmonary artery. That's the aorta there. But then you've got your SVC, and then you've got other things sitting here, and another thing sitting over here. Can you see that? And as you come up and down, they kind of come in and disappear again. And those are called lymph nodes. So you've got a few lymph nodes there. They're not massive, but they are bigger than they should really be. And coming further down, can't see any other lymph nodes anywhere. Can you? Maybe there's one there. But as you come further down, you can see that there is something a bit abnormal about this area over here. So what you actually do now is go to the lung windows, and you can see that it's got these linear sort of hypodense areas over there. Can you see that? And they look like straws sitting within a glass of water or a glass of gunk. And that's essentially what it is. It's a straw sitting within a cup, which is the lungs, and the straw stays patent with air within it. But the lungs are full of like this fluid, and that's what we know as consolidative changes. And so this is extensive consolidation and there's a few kind of areas where it looks a little bit sort of shadowy, a bit hazy, and that's known as ground glass change. So you've got a combination of ground glass change and this consolidated change is located in exactly right. Someone said the right lower lobe. And so that's a right lower lobe consolidation. So a few people have asked whether this is a PE. So this is not the best example for looking for a PE because you know how I pointed out pretty much on purpose actually to try and illustrate like why this is not a CTPA and why this is not a CT aorta. And so it can be difficult. And I'm not saying you can't see whether there's a PE. It could be a PE, but I wouldn't bank on it. And I would normally say that there is no large pulmonary embolus if someone calls me up and says, like, is it PE or not? But one thing that I would say that goes against this being a PE-induced issue, because I think a PE, I guess, could cause consolidation because of ischemia, is the fact they've got so many enlarged lymph nodes, right? So you can get, you can get infarcts, but the fact this person's got a few enlarged lymph nodes, and on this particular phase of imaging, I can't see a PE anywhere. And if you do see one, do tell me where you think it is, and I can try and take a look. But based on the imaging that we've got in terms of lymph nodes and the consolidation, I would go for infection over anything else. And actually, there might be a small pleural effusion here, maybe very, very small, around the back there. Let's see, maybe not. But yeah, I mean, look, that's the thing. Like, so people are talking about PEs, right? So can infection cause a PE? It could. Can PE cause an infection? Not really, but you can get consolidation as a result of infarction. But when you've got sort of lymphadenopathy, yeah, so the person said, yeah, you're right, that one there, yeah, right, hyaline lymphadenopathy. When you've got lymphadenopathy, then you would actually go for this being infection. Now, someone said, they said, can you get a contrast enhanced study? So this is a contrast enhanced study. So what you actually probably mean is you want contrast, but in the CT pulmonary angiogram. So you want to be a pulmonary angiogram or a CT angiogram phase, right? And so this is not the right phase for that. Yeah, so you definitely want a PE protocol, and that's when this will be very, very bright if you want to be looking into this. But again, also you've got to think about the clinical picture. Did this person come in with infection, or did they come in with acute shortness of breath? I remember this patient. What ended up happening was this patient came with consolidation. Then they were treated. Then they came back and the consolidation didn't get much better. And then we did a CT chest under pelvis to look for a malignancy, and there was no malignancy from what we could see, and therefore we put it down to being infection. So yeah, this wasn't a P on this one. Right. So let's go on to the next case and this image, and this is a chest X-ray of an adult. Okay, I'm just gonna have to drink water. Right. Right, so we have got an adult patient, and we can probably infer that they're a bit older, I guess, because look at that acromioclavicular joint. There's a bit of osteoarthritis probably sitting there. The glenohumeral joints look okay, not much in the way of calcifications of the chest. Hyla, so let's have a look. So let's have a look at the lungs. So yeah, people have gone for it already, and yeah, that's fair enough, right? You can see that there is some abnormality located in it, but I want to give some of you guys a bit of a system. So obviously have a look at the lungs. If you haven't seen anything else, have a look at the lung apices as well, and have a look at the lung apices and see what you think. And actually, you know how last time um, there was that issue with I have not heard the word pink puffer in a long time. Wow, that brings back a lot of memories. I'll go into that in a second. Um, okay, so you draw your little squares, and then you know the last case, what we saw was there was a lack of lung markings, right? And this time there is a lack of lung markings, but in a different way, in that there is now some sort of apical thickening located within that region, right? So there's something kind of dense within that region, right? And so one of the things I'll try and do is have a look at that area over there and say, okay, is it bone? Is it soft tissue? Is it lung? So because it's kind of dense, but doesn't look like bone, because bone looks like this, so it can't be calcifications. It looks like it's some sort of soft tissue abnormality, right? So you think to yourself, okay, well, actually, as someone gets older, you can get apical scarring, and that's very, very normal because you don't have as much blood flow to the lung apices, and then you can get scarring, and then that can cause a few issues. But with this one, in this particular situation, it's asymmetrical, isn't it? It's very, very asymmetrical in terms of how dense that is compared to there. Like if you went there, you could say, yeah, okay, there's a little bit of apical scarring there, but this is very, very thick indeed, right? So let's have a look at the rotation. Remember we talked about rotation? So that's that end of the clavicle there, that's that end of the clavicle there. And we can see that there is a sort of spinous process that is sitting over here. So that actually is pretty well centered, right? So basically, they're not particularly rotated. So that's not them being like this or like this. That's kind of almost on fast as best as you can get. And you've still got the sort of, you can't explain this away, right? Now, let's have a look at the hilum. That's the hilum there. Where's the other hilum? The other hilum's here. So this looks like it's been pulled upwards, doesn't it? So this looks like some sort of apical scarring going on, right? This doesn't look quite normal. Few people have said that do they look like hyper overinflated lungs? Yeah, I mean the lung, after a while, it can be it can be. I think over time you start to kind of get an idea about what the lung markings should look like, and when they look a little bit porous or they don't look like as many lung markings as there should be, then you can start to infer that there could be some sort of underlying emphysema. Now, could this be a left upper lobe collapse? Now, usually when you do get a proper left upper lobe collapse, you do end up getting like a veil-like capacity or something along those lines. This one just looks very sort of wedge-like, and it looks like it's kind of almost solid. And the fact that everything's kind of pulled towards it. Look at that tracheus going towards it. You've got your apica, you've got your hilum going towards it as well. You've got to start worrying so there could be something else going on there, and therefore this person would end up needing to go get a CT scan. And from what I remember, this person's still under investigation for this one. Is kind of a bit more hot off the press, this one. But I thought it was quite interesting just to kind of illustrate the rotation and the hilar, being pulled up and all that kind of thing. And in this particular one, you don't have much in the way of the hemidiaphragm being pulled up, and that's what you'd get with a sort of a larger collapse and a larger sort of apical scarring and that kind of thing. Right. So yeah. So this is clearly an abnormal area. We can't explain it away. It's got apical mass, which is causing some tethering of the surrounding structures. It's causing a midline shift towards the left of the trachea, and it's causing some left hilar elevation because towards it as well, which you can see. Look, that one there and that one there, the hilar completely out of line with one another. Right. Okay, cool. So we're going to go slightly, well, I don't want to say easier. We've got some really good cases coming up. But like I said, some people have got varying levels of experience when it comes to these X-rays. So we just have a look at this one first. So I'm looking at we're having a look at this ankle, right? And on this view, it doesn't look like there's a huge amount going on. And so one of the things I would always do is have a look at that sort of talar dome and have a good look around, just make sure there's no osteochondral defect. And for those that don't know, an osteochondral defect is where you've got an osseous defect, and you'll see something like this or something like this. It'll kind of look a bit radiolucent or anything like that. It will look kind of abnormal in that area. And there's gradings of osteochondral defect. And actually, generally speaking, the most likely place you'd get an osteochondral defect is going to be in the supremedial. So that's going to be medial because that's medial malleolus, supremedial talar dome. But this one doesn't seem to have anything like that. And actually, in truth, the next place I want to look at is the base of fifth, because so often you have a base of fifth fracture that you just won't see because you're looking at the ankle. And then again, have a look at everything else. Everything else looks okay. I haven't seen anything grossly abnormal. Some people might start to worry that line there, can you see that? is some sort of fracture. But actually, when you look at the adjacent areas compared to that line, it looks very, very well sclerosed. So it's going to be most likely a vascular channel. So on this view, I mean, if you've seen it, great, well done. But we haven't, it's not entirely obvious until you go across to this other view over here. And when you go to this view and you zoom in like so, and then pan across like this, um, you'll see that there is something slightly abnormal. So let's draw around. So this is going to be the tibia. We're coming around this way, and then the tibia does this, like this. And it feels like there's an abnormality maybe here around the back over here. But actually, more importantly, as well, we're going to come over here, and then you can see that there is radiolucency does this. And then you can keep drawing like this, and this goes all the way around like so, like so. So what I've essentially done is drawn a fibula, so lateral malleolar fracture, and I would be concerned there's also a posterior malleolar fracture as well. Then we should probably look and see whether this could be a trimalleolar fracture, where you've got medial, posterior, and lateral. But actually, I can't see a medial ankle fracture at all. So actually, everything else looks okay. And then you want to make sure that there is no calcaneal fracture as well. And the way to do that is have a look at the trabeculations, make sure that you can see the trabecular pattern going all the way along like this. And if there's any disturbance in that trabecular pattern, then you will be concerned about a calcaneal fracture. But there's no calcaneal fracture. We can pretty much say that, yeah, it's most likely a lateral malleolar fracture and a fracture through the posterior tibial plafond, with most likely some articular surface involvement as well. No other fractures at all on this one. And actually, if you come back to this one and you zoom in again, we thought it was normal. When you kind of look in retrospect, you can see there is something abnormal there, I suppose. But more importantly, if you go and look at your own ankles, unless they're swollen, generally speaking, your skin should really be right against there. Yeah, I mean, you could put your hand on your lateral malleolus and feel your bone straight under. And when you've got that level of sort of soft tissue thickening, you really got to start thinking there might be something up. There could be a ligamentous injury, or there could just be I mean, like we've seen on this particular occasion, there is actually a fracture, but there could be ligamentous injury, soft tissue injuries, but there's definitely swelling there that may need to be followed up later. So yeah, some displaced fragments, yeah, in that posterior aspect. Okay, cool. So let's go to this next case. It's a CT scan as well. Okay, so CT outer pelvis, is it contrast or non-contrast? So based on this image, I feel like there's going to be a contrast enhanced study. The reason I say that is because you can look at the vessel over here, and that looks slightly brighter. That looks at the aorta. Aorta is on the left, for those that don't know. And then we just wait for the image to download, but we come from the very, very top first. So first off, we've got the lung bases. Scrolling down, you can see a little bit of kind of stomach poking out there, can't we? So that's going to be a small hiatal hernia. No evidence of ischemia. The stomach actually looks okay from this point of view. We keep going, keep going. I'm going to scroll through one so that if anyone can't see, is not scrolling as well, they will be able to have a look themselves and scrolling through. Did anyone see anything wrong? So yeah, someone's come up with something very good there. Very good. Okay, cool. So there's a few things to be looking at. Yeah. I haven't heard the word dirty mesentery. Oh yeah. So someone said pink puffer earlier. Um, I just wanted to say I can't remember what pink puffer means. I remember that coming up with like COPD and all that, and something to do well, their cheeks are red or something. I'm going to look that up. That's really brought back some memories. Anyway, so let's have a look. So yeah, someone said the liver looks a bit fatty. Yeah, that's right. It does look a bit hypodense. And then as you come further down, yeah, the gallbladder looks a little bit hyper enhancing, doesn't it? But actually, when you come around this area, you can see there's a lot of enhancement. I mean, a lot of fat stranding located within this area. And so you got to think, okay, what could be causing that kind of fat stranding, right? So, yeah, you can get duodenal ulcer. Duodenal ulcers could cause some fat stranding like that. What else could be causing fat stranding? I guess a gallbladder could be causing, but the gallbladder fat looks normal as well. It doesn't look too bad, actually. And then you got to look at the pancreas. So let's have a look at the pancreas. Pancreas goes along like this, goes along like this. And you come to this area over here, and this is where you've got this sort of head of the pancreas. And it's just around there, all looks very, very inflamed. The pancreas itself looks a little bit edematous. So this would be, yeah, exactly like a pancreatitis picture, right? And so when you've got a pancreatitis picture, the rest of the pancreas looks okay, but this area of the pancreas doesn't look normal. And actually, a hyperlipidemia can be a risk factor for pancreatitis, and this person does have a fatty liver. So that is one of the things to be concerned about or thinking about. But complications of pancreatitis can be, look, you've got to think about location now, yeah? You've got a splenic vein, which is sitting right next to the pancreas. You just got to look, does that look like it's blocked off? Because that could be a problem. You got your You got your renal vessels that are not far as well. Could they have a problem? So they actually are okay at the moment. Someone's gone for cancer of the pancreas. Now, again, it does depend on the clinical history of the patient. Has this person turned up with weight loss? Have they turned up with pain? What's the amylase looking like? Of course, those things are possibilities and may need to be looked into later once this person has had been treated for this initial bout of pancreatitis. But this is actually just a straight up pancreatitis, and I thought it was quite good because it can start to make you wonder, like, where is this coming from? Is it coming from the duodenum or anything else? Now, interestingly, this person, if I remember correctly, does have a small renal stone that's not causing any issues, and they've got some calcification located within the SMA, and that can be sometimes worth noting because sometimes you've got someone who's got lots of abdominal pain, you've done your scans, you can't see anything abnormal, but you do see a bit of calcification located within the one of the mesenteric vessels, and then it may be worth doing further investigations by getting a mesenteric angiogram, and that may show that there's a bit of obstruction to flow and that kind of thing. So it's all quite interesting stuff. But this one is actually a CT out of the pelvis, portovenous phase. And the big find is got pancreatitis, and you've also got this steatosis as well in the background. Good. So GB will, yeah. So I'm with you, and I initially thought the same thing, but actually, it doesn't look like it's inflamed, right? The gallbladder doesn't look particularly inflamed. It looks like it's a bit thin-walled, and it's also got no fat stranding around it. So actually, I do think it may be as a result of the steatosis around it, right? And that can be a little bit misleading. Um, but I don't think I can buy that. That's definitely inflamed. But undoubtedly the inflammation really is centered around this area over here, if you can see that. Right. So let's have a look at this next case. Okay, so next case. Oh yeah, so these are I've been looking forward to these because they're donated cases, and it's really lovely when someone takes their time to donate a case. And hopefully, like my colleague Danish said, that we'll get this person on and start presenting a few cases as well. So this is a pelvic X-ray, and we are looking at someone because well, hip X-ray, and we're looking at this because someone is concerned they've got pain or groin pain. And so we're going to have a look and just see what's going on. So first off, when you actually draw around the femoral heads, can you see how it kind of does this? It looks very, very kind of roundish around both edges like this. And so that's known as something like CAM deformity, CAM. And that basically means that this patient has got kind of quite a rounded femoral head, which can increase the chances of having impingement because it's not kind of rolling over the underneath the acetabulum as well as it could. If you look at this joint space here, can you see that? And then compared to that joint space there, okay, there's definitely some lack of joint space in that area, and actually looks a little bit more sclerosing in that area as well. That looks actually relatively okay. So there's some osteoarthritis located within this region, maybe a little bit of radiolucency over here, which would suggest that this person's got underlying impingement. So there's definitely osteoarthritis of that right hip. So someone has said that they think there could be a hip fracture. Now, one of the ways to look for a hip fracture is to just have a look at that trabecular pattern, a lot like what we did with the calcaneum, and just see whether these are all okay. And if there's like any sort of discrepancy, any sort of line going across, then you'd be worried that this person's got some sort of underlying hip fracture. Then you look at the pubic symphysis, look at the acetabular rims, they all look okay. And actually, when you come to this area here, can you see that when you try and draw that trabecular pattern like we drew earlier, someone's done it, gone for it, yeah, good. So you can see that there's actually a disturbance in there, but there's not like a linear disturbance. There's like a spherical disturbance located within this area, right? Everything else looks okay. Let's make sure there's no other abnormal lesions, and I can't 100% see any other lesions anywhere else. And when you look at this, and it looks like these kind of calcifications within it, right? So you think, okay, what could that be? And then you look over here. Okay, so you've got a few calcifications sitting within these areas over here. Are these the same? Not really. These look a little bit more triangular. These are kind of these are sorry. These are more spherical, like phlebless. So are these phlebless? Are they not? It can be difficult. We do have other views. Let's have a look. And actually, these. Sorry about this. These haven't changed in appearance, right? Come up to this view, and again, its calcifications are sitting within this region as well. So we're coming back to this, so we can see focal calcifications within it. And this is a well-defined lesion, predominantly hypodense, right? Very, very round. So now you've got to start thinking yourself. So if all you do when you see these kind of x-rays is make a decision, Is this aggressive versus non-aggressive? We have to think about whether it's aggressive versus non-aggressive. That's the big thing, right? So it's got a well-defined contour. You could get a pen and draw that very, very nicely. So this is something that says a non-aggressive, right? Is any periosteal reaction? No, there's no periosteal reaction. So that's a again, non-aggressive lesion. Any soft tissue swelling? Can't definitely see any, and you can see the fat planes quite nicely. So it's not, again, non-aggressive lesion, right? So everything now is pointing to this being a non-aggressive lesion. So now you've got to start thinking about what kind of non-aggressive lesions can you have, which are going to have sort of this sort of calcification sitting within it. And a few people have gone for it. It's more likely to be an intraosseous lipoma. And I know there's like a really long name for it, which I end up always having to look up. But actually, this is a fairly cool case because I don't normally see these in the femur like this. Normally, I see them in the calcaneum, but this is an intraosseous lipoma. And over time, they can have sort of punctate, they can have these kind of calcifications and kind of calcify more and more over time. But the main thing is it's not an aggressive lesion. I should be really worried about it. Well, it depends on how big this lesion actually is, especially in the location that it is, right? If you've got a lesion like this sitting located within the femoral neck, you do have a bit of distribution of force along the femoral neck. So it may be worth doing further investigation to see how big this really is, how much of the femoral neck it actually takes, because if it takes a large proportion of it, that may predispose to someone having a fracture later on, like a pathological fracture, in the same way that you would have a simple bone cyst. Now, why is this not a simple bone cyst? Simple bone cysts are usually very uniform in their appearance, and they're normally in the long bones. And on top of that, when you get a fractured fragment from a simple bone cyst, it would literally be a fragment, not like these kind of punchy calcifications that are just sitting there. So this would really be nothing else but an intraosseous lipoma. And like any other lipoma, it will behave like fat if you did a CT scan, an MRI scan, all those things, right? Okay, cool. So we are going to come up to this case. So this is excruciating knee pain, which I'm actually having these days, maybe because I'm getting a bit older. Right. So have a look at this, and we can see that this is an AP and lateral view of a patient's knee. And they look like they might be slightly older because if you look, they've got a bit of vascular. Can you see that? They've got a bit of vascular calcifications. Can you see all that there? So they must be an older person. You can also tell by just the bones, the way the bones look. They do look a bit. They do look like they are of an older person. And then let's have a look. Can we? Sometimes you've got to be really, really careful. Just make sure that there's no trabecular fracture. I mean, tibial plateau fracture. And all you might see is a bit of a linear line there, linear line there. That looks okay. Is any avulsion? I mean, a linear line over here, a linear line over here, but nothing there. And then any sort of avulsion of the ischial, the tibial spines, they all look okay as well. They don't look particularly bad. And then you look for like a second, is there like a second fracture? Any sort of fracture along there? Can't see anything there either. So now if we come back to this view, people are saying that they feel they can see a joint effusion. So yeah, I mean, look, I don't think you can be 100% that there's an effusion there. I mean, it looks pretty fatty. Pre-patella, so maybe a little bit of thickening, but if you're looking for if you're trying to say a pre-patella bursitis, you probably want something a bit more spherical there. But actually, by all intents and means, it looks pretty okay, doesn't it? It looks normal-ish from what I can tell. So actually, on this X-ray, I don't think I can really say I can see anything grossly abnormal. But we are now going to go on to the MRI scan because if someone's got excruciating knee pain, you're going to have to do more imaging. Right. So I haven't done much in the way of MSK teaching in general these days, and not definitely not on these collective mind lectures. Sorry, I don't know why my throat's getting so dry, red. Okay, so let's have a look. So we're having a look at this MRI scan. So this is sort of your more sort of T1 weighted image. And we're just having a look through. And at first, it doesn't feel like there's all that much going on, right? And what I'll do, I'll try and point out some anatomy for people that are not entirely, well tuned with MRIs of the knee. So first off, what you can see is this is the medial knee, right? I know it's medial knee because of the shape. And for those that don't know, if you're playing golf, right? And you're going to play golf, do you put the golf ball between your legs or on the outside of your legs? Hopefully, if you play any golf, it'll be between your legs, right? And the reason I say that is because this looks like a golf tee, and therefore, if it's between your legs, it's going to be the medial. So this is the medial tibia, and you go right across the other side, and then this one looks a bit like a rifle of a gun, right? So if I had the a shotgun, I wouldn't keep it between my legs for obvious reasons. I keep it on the outside of my legs, and therefore, if it looks like a shotgun, like handle, then it's going to be the outside. That's one way that if someone just presents you with something like this and you're not sure, if it looks like a shotgun handle, it's going to be lateral, and if it looks like you're going to play golf, then it's going to be medial, right? And then you've got your menisci, and these are it's called bow tie shaped things over here. And the medial meniscus, it should really be like this back end is bigger than the front end. And actually, in this one, you can see that that is probably true. Scrolling through, can we see anything grossly abnormal? Not massively abnormal there. And then can you see there's like a line here and then a second line over there? So that's anything between there is going to be your chondral surface. So the chondral surfaces, are they okay? Yeah, they actually look okay, don't they? They don't look too bad. So now when you come to the middle of the knee, you can see that you've got your ACL, which is this line like this. And that can get very, very thick. And sometimes it can get a bit edematous, and that's going to be called mucoid degeneration. It can happen over time. Nothing, it's like a normal thing that can happen over time. And this doesn't look like it's torn. So this looks very, very linear. And then as you kind of keep scrolling, because it's very, very black-like structure, and that's going to be a PCL, and that looks very, very normal as well. It looks like it's okay on this side. Now, if we come to the lateral meniscus, hang on. So come to the lateral meniscus. This is going to be like a proper bow tie, right? This should be pretty much equal on both sides. And actually, yes, this is true. It's actually equal on both sides. Doesn't look like there's anything grossly abnormal there either, right? Fine. So let's keep going. So don't worry. Yeah, I mean, this is not an easy case. I mean, these are all good guesses that you've given so far. Right. So now what we do whenever we're looking at any MRIs is have a look at that patella. So the patella is sitting within the trochlear groove. Have I got the images there? Yeah. So the patella is sitting right within the trochlear groove. Can you see that? Right there, right? And so what happens is that trochlear groove is going to have a slightly longer and steeper side compared to a slightly more shallow side, right? And that's because the patella, if we're left to its own devices, would run away from you laterally. Like what I mean, run away laterally. And so therefore, if it's longer, that means that side is trying to keep the patella in, trying to make building that wall a lot bigger so that patella doesn't run away. And that's therefore going to be the lateral side of the ankle. Yeah. And the shorter side is going to be the medial side of the ankle. And therefore, if you do get a dislocation of patella, the patella would go this way and then would come back again. But before coming back, it'll make a quick visit to that lateral femoral condyle and come back again. But this actually doesn't look like it's done that. There's no bruising on this side because that's what would actually impact over here, but that hasn't happened. And there's no bruising on this side either as well. So this actually looks like it's okay. Now, remember that chondral surface I was talking about? Now, this is a chondral surface like this. Remember, there's two lines. But actually, when you're coming up to this area, it starts to get a bit thin. And then you got a chondral surface again. And then you got a little bit of this edema sitting over here. So you got a bit of loss of chondral surface, a little bit of edema close to the patella apex on that sort of medial patella facet, right? Now, that's one bit of area of chondral loss that we definitely have. We'll come across to this one and just see if we've got any other chondral loss. So remember, we're talking about that V shape where that patella is sitting. Now we're looking at that valley, but from the side. And so now this is where it's useful. Are we lateral or medial? Well, we know we're lateral because of the shape here, but this looks like a shotgun. So therefore we're lateral. And actually, when you come up to this area, you can see that double line there, and it's kind of complete loss of that double line. It's gone. And then you've got no line there. So you've actually got what looks like a complete lack of chondral surface over here. So lack of chondral surface there. And actually, looking closer, a little bit of bone marrow edema there as well. So loss of chondral surface involving what looks like the lateral trochlear facet. Okay, so is that all that we're looking at? Actually, there's a little bit more to this. So someone said quadriceps. Let's have a look at that quadriceps. So that quadriceps is over here, going along like so, and it seems to be attached to that patella quite nicely. Then you got your patella tendon over here, and there's no inflammation over here and no inflammation over here. So that patella tendon looks okay. Can't be 100%. We do have to look at the axial views as well. So let's have a look at the axial views. So this is going to be the patella tendon coming up, coming up, coming up. That looks like it connects quite nicely coming up, and that's the quadriceps tendon. So far, it looks like we haven't seen anything else that's particularly abnormal. Right. So now let's go to this area over here. So, I haven't shown you the ligaments. So let's have a look at some more ligaments before, and this will hopefully give us what we're looking for. So now we're looking straight on. So it's not a quadriceps tendon tear so far. So we have got so this is the medial aspect of the knee. And what you can see is the MCL, and you've got deep fibers and superficial fibers, and they actually look like they're okay. And you've got your LCL, which is this thing over here, and then you've got your bicep femoris and your iliotibial band that connects all the way to the fibular head, and they actually look okay as well. But what should really happen is that this MCL should go all the way down like so, and should be very, very closely associated with the proximal tibia. But in this situation, there does feel like there's something else sitting here. Can you see that? That area over there looks kind of abnormal. There's something sitting, pushing the MCL out. It's not meniscal material that's pushing anything out. It doesn't look like, I mean, when you as you look at it now, you can see, yeah, there's all this kind of material that's pushing everything outwards. There's something very, very abnormal about that area there. So what is this? What's going on? So let's see if we can find this exact thing on the T1 weighted images. So go, and this is what I really like about this platform. I mean, this is literally an online, I mean, Dicom viewer, and this is why I use it for all my teaching, for my registrars and the courses that we run with radiology seminars. We always use this platform because it just seems to do such a good job for us. Right. So now when you come to here, see what that line is, see what that line, you can see this area over here doesn't look normal. There's some sort of weird sort of material sitting there, and it doesn't look like fluid. It doesn't look like fat. It just looks kind of ambiguous, kind of, but slightly isotense with the muscle and the fat in the this particular sequence, but hypointense on the more T1 weighted images, right? So what you've got is someone who's got quite significant pain and what looks like there's some sort of mass or some sort of lesions located deep to the MCL, pushing the MCL out. Now, the other thing that might give it away is that whatever this material is not within the actual joint. So it's actually extra articular, isn't it? It's outside the joint. So extra articular, peri-articular, someone might say. It's a peri-articular soft tissue lesion in a patient with a large joint pain. This is gout. So yeah, this is actually like a gouty tophus, and that's what's causing this person's pain. And what you probably need to do is recommend this person gets their urate levels checked and see whether they've got any other large joint involvement. So knees can be involved. Generally speaking, most people would say it's going to be the big toe. It's very, very common, very, very common finding. Someone who's got gout is going to have big toe problems. Can also happen in the elbow as well. Can happen in the C spine as well, actually. But yeah, so this is like a gouty tophus, and what you may want to do if you're still unsure, take a biopsy, check the urate levels, and see what's going on there. But actually, everything else, it was biopsy. Oh, okay, there you go. So yeah, oh no, I think I read that. Anyway, yeah, so it was biopsied and proven as gout. So this is, I thought, a really interesting case because I've actually got something. Actually, I'm not going to say. I'll bring it up another day, but I do have a similar-ish case at some point in life to show you guys. Right. Let's have a look. Do I have any more? I think we have finished. We have finished. So thank you so much for everyone that has turned up, given me your time. Thank you so much for the donations, the cases. You genuinely don't understand how much I appreciate the donation of cases because it just means that it means so much that you guys are getting value from it. And I really hope that if you guys want to, you can get involved too, get involved, chat, talk, show me some interesting things, present cases if you want to. I really don't mind. I think the whole point is if you're interested in radiology, hopefully you enjoy it. It's a bit of entertainment, a bit of enjoyment, and a bit of getting to know each other and stuff like that. And feedback is so important for me because if you don't know this by now, I really enjoy teaching and I want to be the best teacher that I can be. So if there's something I can prove, do let me know and I'll do the best I can to do it. Okay, so from me, thank you so much. I'm going to hand it across to my colleague. Thank you, everyone, and have a good evening. Bye.
Thank you, Imran, for another great webinar session. I've just posted the link for the feedback form in the chat box now. If you fill that in, and from that you'll receive your CPD certificate. Again, it will just give us some feedback on how we can improve the upcoming webinars. And like mentioned earlier, we've got a few ideas for next year's webinars to include some more MRI scans, to get special guests on the series as well to discuss through their cases. And I just very quickly wanted to show you how, if you do want to share a case with Imran in the upcoming webinar, on the global community, you should all have access to this now. You can upload cases, and then what you need to do is just find a case that you find interesting that maybe you want Imran to go through, click onto the case. That'll bring you onto the case page here, and you can just simply reply and just at Imran Lasker onto the case itself. He'll get notified, and then he can hopefully go through that in the upcoming webinar. The final thing, just about the global community, which some of you might not know, we've also worked with quite a few AI companies on the global platform where they showcase their AI algorithms onto the platform, which is free for you to use, for you to test out, to see what the algorithm's like. And you can simply do this by uploading your cases and requesting the analysis, depending on which algorithm is for that specific modality and for the specific imaging technique. So we like you see here, we've got a few that we work with. So that's just another thing that is able on the global community. So that's everything. We'll see you on the next webinar, which will be on the 13th of December, I believe. So only in 3 weeks' time. So please join us for that, and I'll see you then. Thank you, everyone.